Good morning, everyone, Professor and friends. I would like to present about a hierarchical cluster analysis of concurrent initial adverse events in patients receiving Bpal and Bpalm regimens for drug-resistant tuberculosis in Lower Myanmar. I am Dr. Myesumo from Ministry of Health, Myanmar. I am also master degree student studying epidemiology in Princess Songkla University, and my advisor is Ajahn Polangre Kumwichar and also Ajahn V. I'm very glad to have a chance to present in 46th National and International Virtual Conference on Multidisciplinary Research. So this is my outline of the presentations, including introduction, rationale, conceptual framework, objectives, methods, result, discussions, and recommendations. So according to the WHO Global TB Report, TB stays a major public health threat all around the world, including Southeast Asian region, including Myanmar. Myanmar have a high burden country and also have an incidence of 5.8 TB cases per 100,000 population, with resistant case also high, with an incidence of 24 MDR-RR-TB case per 100,000 populations. So among the burden, approximately 63% of this burden is concentrated in Yangon and Bago regions. To solve this problem, we made a pilot program for shorter regimens in Yangon. According to that pilot study, we found that Bpal and Bpalm regimens are showing high efficacy with a considerable side effect, and Myanmar National TB Program decided to implement Bpal and Bpalm regimens starting from 2024 for the whole countries. So this is the research gap. The past study often reported frequency of each adverse event without considering how patients experience multiple AE at the same time, and no TB study have mapped this time-based clustering pattern for adverse events in treatment of drug-resistant regimens. So this is the figure comparing what is the traditional view considering only one AE, and this is our study. We considering how AE concurrent together and how they link together. So this is the conceptual framework of this study. The objective is to explore pattern of concurrent AE based on similarity in time to first occurrence using heat map visualization of mean difference of time to first occurrence. And the second is to identify cluster of co-occurring events through hierarchical cluster analysis. This is retrospective secondary data analysis using data from 40 MDR-TB centers in Yangon and Bago region. We take the patients' data enrolled in the National TB program between 1st January 2024 to 31st December 2024. We use the data source called Open MRS Electronic Medical Record System. I will explain steps in our data analysis. First, we extract the data and clean accordingly. Then we use only the first occurrence data only and got 1,466 unique AE data. Then we calculate on pairwise mean difference in time to first AE across all event types, normalized on 0 to 1 scales. Then application of using distance and word linkage using standardized mean difference less than 0.1 to map temporally synchronized events. So let's go to result sessions. So this is a cohort of 729 individuals that experience at least one AE. Among them, 87% taking Bpalm and 30% were taking the Bpal regimens. So most of them are male, 61%, and 39% are female. Median age is 40. What we found is 59% of our cohort is underweight, showing that vulnerability of all AE. So this is our main finding. Figure showing heat map with hierarchical clustering of concurrent AE based on first occurrence AE data. We found there is a high density red zone concentrated in lower right quadrant of a matrix indicating close temporal occurrence among multiple AE. So using the mean difference less than 0.1, we found total 7 clusters according to our analysis. So among that 7 clusters, in cluster 1 and 3, we found coordinated systemic and organ stress. In cluster 1, we found 5 AE grouped together, including pruritus, rash, anemia, chest pain, renal failure, insomnia. In cluster 3, contain arthralgia, elevated liver enzyme, and renal failure. This is the main cluster in my study. Cluster 2, the major multi-system toxicity, with a cluster size 8, including headache, muscle pain, arthralgia, palpitation, QT prolongation, elevated liver enzyme, lower GI symptoms, and electrolyte disturbance. Another cluster 4 and 5, showing renal, gastrointestinal, and psychological impact are camped together. Cluster 4 is a renal systemic cluster containing insomnia, renal failure, palpitations. Another cluster 5 contains epigastric discomfort, elevated uric acid, anxiety, depression, and nausea, vomiting. This cluster 5 showing more GI distress. So this is cluster 6 and 7. Cluster 6 contains visual disturbance, peripheral neuropathy, and thrombocytopenia. And cluster 7 contains delay independent, including the symptoms like leukopenia, hearing disturbance, and hypothyroidism. And this is the cluster that occur in the last time of treatment durations. Then we will move to discussion and recommendation part. So, according to our study result, adverse events may occur together with other types of AE in clusters. So, traditional approach is only check sporadically, may miss some AE, and also delay the response. So, using cluster-based approach, make a comprehensive monitoring of all AE if we found one AE, and also need to check other types of AE that makes early detections of adverse events and target interventions quickly. So for key monitoring and recommendation, we should use integrated clinical, biomedical, and ECG monitoring together, and also need to support like a nutritional support for underweight patients to prevent AE. And also we have to set up the early intervention protocol to prevent AE. So what will impact to the program? So this cluster-based approach may improve the patient adherence, that may reduce the treatment discontinuations, and make the treatment outcome better. So, as a conclusion, this is the novel and first study using heat map and hierarchical clustering methods in the analysis of a safety data of adverse events in drug-resistant TB. I would like to thanks to my advisor for supporting me throughout my study, and I would like to thanks to Myanmar National Program for implementing such a good regimens, and also thanks to clinician, nurse, data manager, and field staff in Yangon and Bpal region. I would like to thanks to Open Medical Record System team to have such a good quality data, and also but not the least, all patients that affect by drug-resistant tuberculosis for sharing their experience in my study. So thank you very much for everything, and this is the end of my presentation.